Okay, so hi friends, a very good evening to all of you. Welcome to this session of one-shot revision in pediatrics. I'm Dr. Pankaj Tikku. I'm the pediatric faculty at eGurukul, and I will be taking your FMG important topics for the exams. The basic aim is to uh, help you revise most of the important topics which I feel are relevant from the examination point of view. So, let me start by first telling you some uh, high yield topics which I feel are important from the FMG examination point of view. So let us start with the topics and we'll be discussing the things which I feel are relevant from the FMG point of view. I hope everyone is just hold on for a minute, please. Just a moment, please. Okay, so now I will be telling you some important topics which are highly topics from pediatrics uh, in FMG. Uh, the first topic is growth and development, and in growth and development, the first important topic is milestones. I feel milestones are very important from your FMG point of view, and every FMG exam milestones you should be very well prepared. Another very important topic which I feel is important from your examination point of view is malnutrition. Malnutrition again is a very important topic, especially kwashiorkor, marasmus, differences between kwashiorkor and marasmus. And then very important, severe acute malnutrition. Severe acute malnutrition is again a very important topics, and you should be always be very comfortable in answering questions from severe acute malnutrition. Then a few important things that you should know from neonatology. So in neonatology, I would suggest that you go through first general neonatology. Then apart from general neonatology, just properly study respiratory distress syndrome, transient tachypnea of newborn, transient tachypnea of the newborn, then Apgar scoring. So Apgar score again is very important from your examination point of view. Neonatal reflexes. Neonatal reflexes is again a very important topic from your examination point of view. So please be very comfortable about neonatal reflexes also. The neonatal resuscitation again is a very important topic which I feel you should be well prepared from your examination point of view. Well, about heart diseases, congenital heart diseases, I will not uh, ask you to go into the detail about heart diseases because for FMG exams, heart diseases are not very frequently asked questions. But at least you should be comfortable and familiar with the important heart diseases, which are acyanotic, which are cyanotic heart diseases, chest X-rays of important heart diseases, which is the most common, which is the most severe, which is the one which presents in the neonatal period. So we'll do about that. Then in gastroenterology, I would think that important topics in gastroenterology should include the surgical gastroenterological disorders, such as Hirschsprung disease, hypertrophic pyloric stenosis, diarrheas, and dehydration management in children. So these again are the things that I think you should be very familiar with. Dehydration management, particularly how to manage no dehydration in children, how to manage some dehydration in children, how to manage severe dehydration in children, all of that you should be very familiar with. Then pediatric neurology, important topics, neural tube defects. Very important topic for your exams, neural tube defects. Seizures, a lot of question asked on seizures, childhood seizures, neonatal seizures, drug of choice for childhood seizures, drug of choice for neonatal seizures, absence seizures, infantile spasms. So these again is a very important group of topics that you should be well prepared for your exams. Then another very important topic which I feel for your exams is cerebral palsies. So cerebral palsies, just remember the types of cerebral palsies, which cerebral palsies are commonly seen after neonatal jaundice, which cerebral palsies are commonly seen in preterm neonates. So just a few things that are important about cerebral palsies, not in great detail. In neurology, I think the most important topics are neural tube defects and seizures. And neural tube defects with folic dose to prevent neural tube defects, very important. Then nephrology, pediatric nephrology, again a very important topic for your exams. And in nephrology, especially glomerulonephritis in children, nephrotic syndrome in children, very important topics. Differences between different types of glomerulonephritis, especially between IgA nephropathies and post-streptococcal glomerulonephritis. That is again something which is very important. And finally, about respiratory disorders, I would think that you should think about topics such as asthma, bronchiolitis, then many topics which are overlapping with ENT, croup, epiglottitis, management of croup in children, epiglottitis management, laryngomalacia. So these again are some important topics which I feel: bronchiolitis, asthma, laryngomalacia, epiglottitis, cystic fibrosis. Again, a very, very important topic these days, cystic fibrosis. And finally, just a few infections that you should be familiar with: measles, chickenpox, diphtheria, tuberculosis. So these are some important infections that you should be familiar with. So I think if you are prepared, well prepared with these topics, which I feel are very high yield topics from your FMG point of view, at least in pediatrics, I think you can score very well. So let me start with a few important things which I feel are relevant. And the first important thing that we will start with in our revision class is growth, development, and malnutrition. So first is growth, development, malnutrition. First that you should remember are the different markers of growth assessment in children. So different markers of growth assessment in children. So you should know about the age dependent markers of growth assessment. and you should know about the age-independent markers of growth assessment. So markers of growth assessment that require age are known as age-dependent markers. Markers of growth assessment that do not require age to tell whether the child is normal or not are known as age-independent markers of growth assessment. So age-dependent markers of growth assessment, you should know about weight of the child. You should know briefly about height or length of the child, and you should briefly know about the head circumference of the child. So weight, length or height, and head circumference. These are the age-dependent markers for assessment of growth in children. Which are the age-independent markers? One of the most important age-independent markers is the mid-arm circumference of the child. And in mid-arm circumference, please remember the instrument that is used to measure the mid-arm circumference, which is the Shakid's tape. So which is the instrument that is used to measure the mid-arm circumference of the child? The Shakid's tape. Usually mid-arm circumference measured between 1 to 5 years of age. Sometimes can be measured between 6 months to 5 years of age. So, but usually measured between 1 to 5 years of age. So be very familiar with age-dependent markers, age-independent markers of growth assessment. Then short stature is another important topic for your exams, and I often teach short stature in my exams, in my classes. So short stature. In short stature, you should just remember two important things, which is the most common type of short stature. The most common type of short stature in children is usually the constitutional delay. Constitutional delay is the most common type of short stature in children. Then which is the type of short stature which is a physiological short stature and associated with normal bone age. That means which type of short stature is associated with no abnormality. So I told in my classes that short statures are of two types. One is physiological, when the growth velocity is normal, and pathological, when the growth velocity is reduced. So physiological short statures includes familial short statures and constitutional delays. So which type of short stature is overall the most common type? It is a constitutional delay. But which type of short stature is the short stature which is associated with a normal bone age, which means bone age matches with the chronological age? It is a familial short stature. It is a familial short stature. So familial short stature is associated with bone age matching with the chronological age. Now, which type of short stature is a short stature in which the child has a bone age matching with the chronological age and is a type of physiological short stature? It is familial short stature, where the child is short because of short parents. The other type of physiological short stature is a constitutional delay. In a constitutional delay, the child is short, but usually the child does not have any pathology. So because the child does not have any pathology, so the child is considered to be a case of physiological short stature. The constitutional delay is overall the most common type of short stature in children. Then another question is which type of short stature, physiological short stature, is associated with delayed puberties? Which type of physiological short stature is associated with delayed puberties? It is again a constitutional delay. So constitutional delay is a type of physiological short stature which is associated with delayed puberties. On the other hand, which type of physiological short stature is associated with history of short parents? It is a familial short stature. It is a familial short stature. Then another important thing, which is the type of physiological short stature in which the final height is usually normal. It is again a constitutional delay. It is a constitutional delay. So, few important things about short stitches. First, which is overall the most common type of short stitcher in children? It is a constitutional delay. Which is the type of short stitcher, which is a physiological short stitcher, is associated with a normal bone age or normal skeletal maturation. So there are two types of physiological short stature. One is familial short stature, the other is constitutional delay. In a constitutional delay, even though it's a physiological short stature, the bone age does not match with the actual age. But in the case of a familial short stature, the bone age usually is matching with the actual age. Then physiological short stitches are also the type of short stitches which are associated with delayed puberties. So there is a history of delayed puberty. But in the case of familial short stature, there is a history of the child having short parents. So one parent or both the parents will be short in the case of a familial short stature. The final height, again a very important difference between them. The final height is usually always short in the case of a familial short stature, while the final height is usually normal in the case of a constitutional delay. So these are some of the important topics which some of the important things that you should remember for your FMG exams from short stature. Then another very important topic which I feel is relevant from your examination point of view is milestones. So just a few important milestones that I would like to tell you. First, when does the child sits with support? The child sits with support at the age of about 5 to 6 months. When does the child sits without support? The child sits without support at the age of about 8 months. Then when does the child starts to crawl? The child starts to crawl at the age of 8 months. When does the child starts to creep? The child starts to creep at the age of 10 months. Then fine motor milestones. When does the ulnar grasp develop? Ulnar grasp. When does the ulnar grasp develop? When does the ulnar grasp develops? The ulnar grasp develops at the age of about 6 to 7 months. When does the radial grasp develops? Radial grasp develops at the age of 8 to 9 months. When does the pincer grasp develops? The pincer grasp develops at the age of 9 months. So these are types of palmar grasps. Ulnar grasp is when the child is holding objects using the ulnar aspect of the palm. It's an immature palmar grasp. This develops at 6 to 7 months. Radial grasp is the child is catching hold of objects using the base of the thumb. This part, like this. Base of the thumb. This is a radial grasp. It appears at the age of 8 to 9 months. This is the pincer grasp. Pincer grasp is objects being held between the thumb and index finger. This is the pincer grasp. Pincer grasp appears at the age of 9 months. But a mature pincer grasp appears at the age of 12 months. So pincer grasp which appears at 9 months is an immature pincer grasp. A mature pincer grasp appears at the age of 12 months. Then another very important milestone is language related milestone. So when does the child starts to babble? The child starts to babble at the age of about 6 months. When does the child starts to speak in jargons? The child starts to speak in jargons at the age of 15 months. When does the child start to speak in sentences? The child starts to speak in sentences at the age of 2 years. So in babbling, the child is speaking in monosyllables, and now the child is speaking the monosyllables fluently. He soon starts combining these monosyllables, ma, ba, da. So he starts combining these monosyllables together. So babbles at the age of 6 months. but speaks in jargons. Now in jargons, he knows some meaningful words, but he's still not able to combine the words into a sentence. So when there is combination of words, but not in a sentence, that we call it as jargon. The child jargons at the age of 15 months, but the child speaks in sentences at the age of 2 years. Then social milestones, such as a social smile. So the child shows a social smile at the age of 6 to 8 weeks. The child shows a social smile at 6 to 8 weeks. He recognizes the mother. He recognizes the mother at the age of 3 months. He recognizes the mother at the age of 3 months. He can identify his gender identification at the age of 3 years. He can identify color identification at the age of 3 years. Then complete bladder control. Complete bladder control is at the age of 5 years. That is why they say never make a diagnosis of enuresis before the age of 5 years. Because a complete bladder control develops at the age of 5 years. So never make a diagnosis of enuresis before the age of 5 years. Enuresis is immature bladder control. And what is the drug of choice for enuresis? The drug of choice for enuresis is oral desmopressin. Desmopressin is a synthetic analog of antidiuretic hormone. So oral desmopressin is the drug of choice. But the treatment of choice is not desmopressin. Desmopressin is the drug of choice. The treatment of choice for enuresis in children is bell and alarm therapy. It's a non-pharmacological treatment. Bell and alarm therapy. So remember, treatment of choice, bell and alarm therapy. But the drug of choice is oral desmopressin. So remember, again, a very important topic for your exams, enuresis, treatment of enuresis. Remember, treatment of enuresis is bell alarm therapy, non-pharmacological. But the drug of choice is oral desmopressin. Then coming to another important topic for your exams, which is malnutrition. Another important topic for your exams is malnutrition. Now, in malnutrition, differences between kwashiorkor and marasmus. Very important topic, differences between kwashiorkor and marasmus. Kwashiorkor is associated with the edematous appearance, spitting edema. So kwashiorkor is associated with edema. Marasmus is associated with the severe wasting. Kwashiorkor is often called as the fat sugar baby appearance. This was an FMG question, previous year FMG question. Fat sugar baby appearance. While marasmus often, because of the loss of fat from the face, the cheek muscles, the children who have marasmus often have a monkey face appearance. Then kwashiorkor children often have associated mental changes. Now this is a very important, very important thing to remember for your exams. Mental changes are seen in kwashiorkor, apathy, irritability. Mental changes are not a feature of marasmus. It's a very important thing that you should remember for your exams. Children who are having marasmus, in fact, actually are very alert children. They do not have the classical changes, mental changes that are seen in kwashiorkor. Then kwashiorkor is also associated with anorexia, poor appetite. while children with marasmus often have a very voracious appetite. Voracious means eagerness. They eat eagerly, they are hungry. The skin changes and hair changes of malnutrition, like flag sign, which is a hair change, alternating areas of hyperpigmentation. These skin changes and hair changes are also more commonly seen in kwashiorkor in comparison to marasmus. I think if you remember this much differences between kwashiorkor and marasmus, I think it is ample for your FMG exams. Edema in kwashiorkor, wasting in marasmus. Fat sugar baby appearance in kwashiorkor, monkey face appearance in marasmus. Mental changes like apathy, irritability in kwashiorkor, alert kind of a look in marasmus. Anorexia, poor appetite in kwashiorkor, a voracious appetite in marasmus. Skin changes, hair changes in kwashiorkor, usually very rare skin changes and hair changes in marasmus. So this is again a very, very important topic for your exams. Differences between kwashiorkor and marasmus in children. Then another very important topic is the definition of severe acute malnutrition in children. In fact, again a previous year FMG question. The differences between, the definition of severe acute malnutrition. So any child who is between 6 months to 5 years of age and has one of these three criterias. Any one criteria is enough. First, bilateral pedal edema. The child has a bilateral pedal edema, swelling in both the legs. Second, weight for height. Weight for height of the child is less than -3 Z score or -3 standard deviation. The weight for height of the child is less than -3 Z score or -3 standard deviation from the expected. When I write minus, it means below the normal. When I say plus, it means above the normal. So when I say -3 Z score, that means the weight for height of the child has fallen 3 standard deviation below the normal. And third is the mid-arm circumference of the child, which is less than 11.5 centimeters, which is again an indicator of severe malnutrition. So any child who is between 6 months to 5 years of age and has any one of these three criteria present, bilateral pedal edema, weight for height less than -3 Z score or -3 standard deviation from normal, and mid-arm circumference less than 11.5 centimeter. This is an indication that the child has a severe acute malnutrition. Very, very important topic again for your exams. So I have told you about severe acute malnutrition criteria. I have told you about differences between kwashiorkor and marasmus. There is a student who is asking about the milestones. So just quickly, I will tell about the milestones, but do not go into the details because ultimately, please understand this is a very short revision class. So I won't be able to obviously teach you the whole of pediatrics in this, but I'm just trying to help you out by telling you some important stuff about pediatrics, which will be relevant from your examination point of view. So in gross motor milestones, I told you, when does a child start to sit with support? 5 months, 5 to 6 months. He's able to sit with support. When is he able to sit without support? 8 months. When do children crawl? So 8 months. When do children creep? Creeping. Creeping is walking on hands and knees with abdomen lifted above the surface. Crawling, abdomen is touching the surface. Creeping, abdomen is lifted above the surface. So the child crawls at the age of 8 months, but the child creeping at the age of 10 months. Crawling 8 months, creeping 10 months. Then in fine motor milestones, I told you about the palmar grasp. So when does the child shows an ulnar grasp? That means catching hold of objects using the ulnar aspect of the palm, 6 to 7 months. Radial grasp, catching hold of objects using the base of the thumb, like this, 8 to 9 months. And pincer grasp, this is the pincer grasp, 9 months. But the pincer grasp at 9 months is an immature pincer grasp. So when does a mature pincer grasp develops? 12 months. Then in language, I told you the child starts to babble at the age of 6 months. But soon he starts speaking meaningful words. So he starts combining those meaningful words and jargons at the age of 15 months. He starts speaking in sentences at the age of 2 years. In social milestones, I told you, social smile develops at 6 to 8 weeks. So by 2 months, children show a social smile. They can recognize the mother by the age of about 3 months. Then children can show gender identification. They can identify their gender at the age of about 3 years. Color identification. Most children start identifying colors by the age of 3 years. Then I told you, bladder control is immature below 5 years. So when do children become dry by day and dry by night? That means when do they achieve a complete bladder control? It is at the age of 5 years. And that is why a diagnosis of enuresis should only be made after 5 years. Then another very important question is, enuresis, what is the treatment of choice for enuresis? It's non-pharmacological treatment, bell alarm treatment. But what is the drug of choice? It is oral desmopressin. Stunting is basically, so there is a student who's asking the difference between wasting and stunting. Wasting is basically acute malnutrition, loss of weight. Stunting is basically height is not being gained. So it's a chronic malnutrition. At least 6 months of malnutrition is required before stunting starts. Stunting means height is not increasing. Wasting means a child is losing weight. At least 6 months of malnutrition is required before stunting starts. So stunting is a feature of chronic malnutrition. Wasting is a feature of acute malnutrition. Now coming to some important topics about neonatology. In neonatology, just remember first few important things about a newborn. So a normal newborn, what are the important things that you should remember for your exams? A normal newborn has a length of 50 centimeters. A normal newborn has a head circumference of about 35 centimeters. A normal newborn has a heart rate of about 110 to 160 per minute. A normal newborn has a respiratory rate of about 40 to 60 per minute. A normal newborn has a normal temperature between 36.5 to 37.5 degrees centigrade, and the upper segment to the lower segment ratio of a normal newborn is 1.7:1. So these are some of the first important things that you should remember about a normal newborn. Most of them are anthropometric and normal vitals. So a normal newborn has a length of 50 centimeters. A normal newborn has a head circumference of about 35 centimeters. A normal newborn has a heart rate of about 110 to 160 per minute. A normal newborn has a respiratory rate of about 40 to 60 per minute. A normal newborn has a temperature of 36.5 to 37.5 degrees centigrade. So whenever the temperature of a newborn is less than 36.5, we call it as hypothermia. Hypothermia, a cold child. And whenever the temperature becomes more than 37.5, we call it as hyperthermia. So if you are asked what is the normal temperature for newborn, the normal temperature for newborn is 36.5 to 37.5 degrees centigrade. So below 36.5 is hypothermia, above 37.5 is hyperthermia. What is the most common method by which the newborns, they produce heat? Normal newborns, they cannot shiver. So the most common method by which the newborns produce heat, generate heat, is called as non-shivering thermogenesis. Non-shivering So non-shivering thermogenesis, which is the most common method by which newborns produce heat. The newborns produce heat by a mechanism which is called as non-shivering thermogenesis. And that is basically by heat production through brown fat. So if someone asks you what is the most common method by which newborns produce heat, the most common method by which newborns produce heat is the mechanism which is called as non-shivering thermogenesis, brown fat. And students often ask me this question, so why is a fat of the newborn brown, this brown fat, why is it brown? It is because of mitochondria. A lot of mitochondria present in this fat. Our fat is white adipose tissue. Our fat does not contain mitochondria, so many mitochondria. But in a brown adipose tissue that newborns have, they have a lot of mitochondria, which helps in the generation of heat. Then another very important FMG question is the definitions of SGA, AGA, and LGA. SGA is small for gestational age baby. It is birth weight which is less than 10th percentile. So whenever the weight of the child is less than the 10th percentile, we call it as a small for gestational age baby. 10th percentile for the gestation at which the child is born. Whenever the weight of the child is between 10th to 90th percentile, we call it as an appropriate for gestational age baby. And whenever the weight of the child at birth is more than the 90th percentile, we call it as a large for gestational age baby, like infants of diabetic mothers. So remember the definitions. And since there are some similarities between SGA and IUGR also. Now there are some differences also, but let us not, this is a revision class, let us not go into the details. Our basic objective should be that in the shortest possible time, let us just revise some important topics of pediatrics. So if someone asks you, what's the definition of an IUGR baby, intrauterine growth retardation? The definition is almost similar as an SGA baby, and that is birth weight of the child less than the 10th percentile. This again is a very important topic for your exams. Very important topic for exams. The definition of intrauterine growth retardation. So if someone asks you what's the definition of intrauterine growth retardation, it is a birth weight less than 10th percentile. Then another important topic of your exams, differences between preterm babies, term babies, post-term babies. Preterm babies are babies who are born less than 37 weeks gestation. So those babies who are born earlier than 37 weeks gestation, they are called as preterm babies. Those babies who are delivered between 37 to 42 weeks gestation, they are called as the term babies, mature babies. And those babies who are born after 42 weeks gestation, they are called as post-term or post-mature babies. Then the first stool of a newborn is called as meconium. Please remember, meconium should pass by 24 hours after birth, and the first urine of the child should pass by 48 hours after birth. This is again very important. So if someone asks you, by when should a newborn pass his first meconium? A newborn should pass his first meconium by 24 hours. Meconium is the first stool of a newborn. It's greenish in color, green color. So newborns should pass meconium by 24 hours. And newborns should pass their first urine by 48 hours. But if I ask you, should you start investigating if a newborn has not passed meconium by 24 hours? Answer is no. Newborns should pass their first stool by 24 hours. But you start investigating only if the newborn has not passed meconium, even by 48 hours. So even by 48 hours, if the newborn has not passed meconium, then you start investigating. But for your examination point of view, someone asked, newborn should pass meconium by 24 hours. Newborns should pass urine by 48 hours. Then Apgar score. I would have loved to ask questions from you. I would have loved to revise the topics again and again. I, in my classes, revise a number of times. So anything that I teach, I revise it a number of times for you people in FMG classes, because my idea is very simple, that more and more you keep on revising a topic, the better it will go into your head. But unfortunately, because this is a revision class, a very short revision class, and a lot of pediatric topics which I feel are important to discuss, so we are not able to revise that much. But even if I think you are able to do this over the next 2 hours that I will be teaching you, I think you are done with most of the important topics of pediatrics. So another very important topic of pediatrics is the Apgar score. Now, as you must be knowing very well, Apgar score is basically a score for evaluating a newborn at 1 minute and 5 minutes after birth. It has 5 criteria: appearance or the color of the child, then pulse or heart rate of the child, then grimace or reflex irritability of the child, then activity or tone of the child, and respiration of the child. Respiratory rate is not counted. It is only seen whether the child is breathing regularly, not breathing regularly, or there is no breathing at all. So respiratory rate is not seen in children with Apgar score. Heart rate is seen, not respiratory rate. Now, if the Apgar score of the child is less than equal to 3, we say the child is severely depressed at birth. If the Apgar score of the child is between 4 to 7, we call the child as moderately depressed child. And if the Apgar score is more than 7, we say that the child is a normal child. This again is very important from your examination point of view. So we are marking in the notes, very good. So very good that you're marking the notes. So this just, if you mark in the notes, all the more important. You will help revise. And there is a question, how many questions are asked in the exams? I would say at least be prepared for about 10 to 12 questions from pediatrics, 4 questions from pediatrics, minimum 10 to 12 questions. There are more also, but 10 to 12 the minimum. So when the Apgar score is less than 3 or less than 3, we call it as a severely depressed child. When the Apgar score is between 4 to 7, we call it as a moderately depressed child. And when the Apgar is more than 7, we call it as a normal child. And Apgar, please remember, is always evaluated at 1 minute and 5 minutes after birth. Then another very important topic for your exams is neonatal reflexes, the timing of appearance and disappearance of neonatal reflexes. This is again a very important topic for your exams, the timing of appearance and disappearance of neonatal reflexes. I will just be telling you the important timings of disappearance of neonatal reflexes. So please remember them for your exams, the timing of disappearance of neonatal reflexes. So, for example, the grass reflex. The grass reflex disappears by about 3 months of age after birth. The rooting reflex. The rooting reflex disappears by about 1 month. So by 1 month, the rooting reflex is not very prominent. Morose reflex. A lot of questions asked on Morose reflex. Morose reflex usually disappears by 3 to 6 months of age. So please remember, if someone asks you, persistence of Moro's reflex beyond what time is considered abnormal? Persistence of Moro's beyond 6 months is considered abnormal. So if Moro's persists beyond 6 months, it is considered abnormal. Then asymmetric tonic neck reflex. Asymmetric tonic neck reflex disappears by 4 to 6 months. These are called as primitive reflexes because they all appear in the intrauterine life. They are controlled by the primitive part of the brain, which is the brainstem. They are called as primitive neonatal reflexes. And primitive neonatal reflexes, as you would expect, which are primitive, they will have to disappear after birth. So anything which is primitive has to disappear. And if they do not disappear by this time, this is abnormal. Now, there are some reflexes which do not appear before birth. They appear after birth, like a parachute reflex. Parachute reflex is not a primitive reflex. Another very important question, FMGE exam. Which of these neonatal reflexes is not a primitive reflex? Parachute reflex is not a primitive reflex. It appears after birth. And parachute reflex never disappears. When does a parachute reflex appears? It appears at 6 to 9 months after birth. And it never disappears. Then respiratory distress causes. So most common cause of respiratory distress in preterm children below 34 weeks is respiratory distress syndrome. And the most common cause of respiratory distress in late preterms plus terms is transient tachypnea of the newborn. So which is, if someone asks you, which is the most common cause of respiratory distress? Which is the most common cause of respiratory distress in preterm children who are born earlier than 34 weeks? It is surfactant deficiency. Respiratory distress syndrome, also called as the hyaline membrane disease, which is the most common cause of respiratory distress in a late preterm child. Late preterm children are children who are born at 35, 36 weeks, just before the time of maturity. So they are called as late preterm newborns. In late preterm newborns or in term newborns, the most common cause of respiratory distress is transient tachypnea of the newborn. So Mithu Kumar is asking if option is 4, 5, 6 months. I think you are asking about ATNRs, asymmetric tonic reflex. Well, very difficult for me to answer because books write 4 to 6 months. I personally would answer as 6 months. But the range that is mentioned is 4 to 6 months. Anyway, so this is the causes of respiratory distress in newborns. Then differences between preterms and postterm children. Differences between preterms and postterm children. So preterm children, they usually have a thin red skin, while postterm children have pale and a desquamated skin. Preterm children have plenty of hairs, which are called as lanigo. So this is a very important term, lanigo. Lanigo are actually the fetal hair. What is lanigo? Lanigo are fetal hair. More is the lanigo, more likely this is a preterm child. In postterm children, lanigo are actually absent. even in terms, the lanugo are very, very little. So more is the fetal hair present, more likely that this is a preterm child. Then sole creases. If you see the creases of the sole of the foot in a preterm child, they are almost absent, or even if they are present, they are very superficial. While in cases of postterm children, the sole creases will be very deep sole creases. Then postterm children also have one more important feature, which is long nails. This is the neat PG question. Long nails present in the newborn usually indicate a preterm, term, or a postterm child. Answer is a postterm child. I would say if exam question is asked, this is the most important features of preterm children. Plenty of lanugo, absent or superficial sole creases. And this is the most important feature of a postterm child, long nails. Plus there are some other features, but these are some of the important features which help you differentiate a preterm child from a postterm child. Then another very important topic for your exams from neonatology. Very important topic from neonatology is infants of diabetic mothers. Infants of diabetic mothers. So what is the most common complication which is present in infants of diabetic mothers? It is neural tube defects. So most common complication that is seen in infants of diabetic mothers is neural tube defects. But the most specific complication is caudal regression syndrome, also called as sacral agenesis. So if someone asks you which is the most common complication in infants of diabetic mothers, it is neural tube defects. But which is the most specific complication in infants of diabetic mothers? It is caudal regression syndrome, where the lower part of the spine, the sacrum, is not developed. It's a very, very specific complication to diabetic mothers. Then infants of diabetic mothers also have congenital heart defects. The most common congenital heart defect in infants of diabetic mothers is VSD, but the most specific congenital heart defect in infants of diabetic mothers is TGA, transposition of the great arteries. So remember these four important things. Most common complication in infant of diabetic mothers, neural tube defects. Most specific complication in infants of diabetic mothers, caudal regression syndrome or sacral agenesis. Most common congenital heart defects in infant of diabetic mothers, ventricle septal defect. Most specific congenital heart defect in infants of diabetic mothers is transposition of the great arteries. Plus, infants of diabetic mothers also have metabolic complications such as hypoglycemia, hypocalcemia. Most of these complications that are occurring in infants of diabetic mothers, most of these complications is because of a hyperinsulinemic state in newborns who are born to fetus of diabetic mothers, who are born to diabetic mothers. So this high insulin levels in the fetus and later in the newborns is actually the cause of most of the important complications, particularly in the fetus. The high insulin levels are responsible for most of the complications. In fact, many congenital malformations are a result of hyperinsulinemia. Then another important topic for your exams, I would say, very important topic is neonatal resuscitation. Now, I don't think I'll be able to teach you the whole neonatal resuscitation in this very short class, but just let us try to revise some important steps of neonatal resuscitation. So the first step of neonatal resuscitation, suppose the child is born and the child is in apnea, not crying. So tactile stimulation should be given. So just hold the foot of the child, one flick on the sole, second flick on the sole. So tactile stimulation should be given if the child remains in apnea after birth. Now, if the child continues to remain in apnea or the heart rate of the child falls to less than 100 per minute, now this is the indication to start positive pressure ventilation. So this again is a very important topic for your exams. What is the indication for starting positive pressure ventilation? AMBU bags in a child of neonatal resuscitation. It is a child who continues to stay in apnea despite giving tactile stimulation, or a child whose heart rate is less than 100 per minute. So in this case, AMBU bags should be started. Next evaluation in these children should be made after 15 seconds. So after 15 seconds of starting AMBU bags, you have to make an evaluation. Is the child improving or not? And the best way to see if the child is improving in neonatal resuscitation is heart rate. Heart rate is the best way to assess whether the child is improving or not. So if someone asks you which is the best criteria for assessment of the child, improvement of the child in neonatal resuscitation, it is heart rate. 15 seconds after starting AMBU bags, positive pressure ventilation, see the child, whether the child is improving or not. And if the child is not improving, so there are certain steps that you need to do, which are called as MR SOPA. So you readjust the mask, you reposition the baby. So baby's position needs to be changed again. Then you need to suction the mouth and the nose of the child. You open the mouth of the child further, because sometimes what happens is that the mouth of the child is not adequately opened, or you increase the pressure with which you are doing AMBU bag ventilation. So increase the pressure of ventilation. And last A is alternative airways. So for example, here you will like to intubate the child. So in case the child has been on AMBU bag with a mask and the child is not improving after birth, then along with the other steps, you need to intubate the child, put in an endotracheal tube, and then start doing ventilation again. And after 30 seconds, of effective positive pressure ventilation, that means you have done 30 seconds of effective ventilation. For example, I have intubated the child. So after intubation, 30 seconds of ventilation by an endotracheal tube. And if the child is still not improving, heart rate falls to less than 60. This was asked in the FMG exam last year. Indication for starting chest compression. Indication for starting chest compression is a heart rate which has fallen to less than 60 per minute, despite giving positive pressure ventilation. And chest compression should always be given with ventilation in 3:1 ratio every 2 seconds. So every 2 seconds, 3 times you do a chest compression, then 1 time ventilation. 3 times chest compression and use the thumbs to compress the chest. 3 times chest compression, 1 time ventilation. 3 times chest compression, 1 time ventilation. Every 2 seconds, chest compression to ventilation ratio should be 3:1. What is the indication of chest compression? Heart rate less than 60. And if still the child does not show any response despite 60 seconds, so 60 seconds of chest compression and ventilation have been given, 60 seconds, and suppose still there is no response in the child, this is the indication to add epinephrine. This is the indication to add epinephrine. So always start with apnea, not breathing. Start the child on tactile stimulation, give tactile stimulation. Despite tactile stimulation, child persists in apnea or the heart rate has fallen to less than 100, start ambu bags, positive pressure ventilation. And when you are giving ambu bags, please remember, in a child who is more than 35 weeks, 21% oxygen should be given. That means room air. But if the child is less than 35 weeks, 21 to 30% oxygen should be given. This again is very important. When you are connecting an ambu bag to an oxygen source, remember, the oxygen should never be more than 30% in less than 35 week preterm child. So if a baby is less than 35 weeks, the amount of oxygen, FiO2 that you will be giving will be 21 to 30%. And if the child is 35 weeks plus, then the only 21% oxygen, that means the room air is enough. If despite giving 15 seconds of positive pressure ventilation, child is still not improving, then some corrective steps which are called as MR SOPA. So you readjust the mask, you reposition the baby, you do the suction of the mouth and nose, which means secretions may be blocking the mouth and nose. Open up the mouth of the child further, increase the pressure with which you are giving ambu bags, and try alternative airways. So till now you were giving ambu bags using mask. Now you intubate the baby. After 30 seconds of effective positive pressure ventilation, after intubation, start chest compression if the heart rate has fallen to less than 60. And chest compression to ventilation should always be in a 3:1 ratio every 2 seconds. And if still after 60 seconds of chest compression to ventilation, child is not improving, then add epinephrine. And believe me, I think in the smallest time possible, I've told you this resuscitation steps. I think this is a very, very important summary, very useful summary. और आप इतना भी याद करते हो, even if you remember this much for your exams about neonatal resuscitation, you are done with it. Neonatal resuscitation, I think, is complete if you are able to remember these steps. And this much of neonatology, I think, is quite sufficient for remembering in a revision just before your exam. So just before your exams, this revision of neonatology, I think, will cover 90% of your neonatology for FMGE. Whatever growth and development I have told, whatever milestones I have told, whatever malnutrition I have told, differences between Kwashiorkor marasmus, severe acute malnutrition criteria, and whatever neonatology I have told, this much is sufficient for your final revision before your FMGE exams, according to me. Obviously, this is has to be added by revising your notes thoroughly before your exams. But this should be quite sufficient before your exams to revise those final topics. Plus, when you read your notes, then obviously the complete revision will be done. Now let us come to so epinephrine 1 is to 10,000 dilution. Yes. Now coming now to pediatric cardiology. So some important things about pediatric cardiology. So which is the most common congenital heart disease in children? It is ventricle septal defects. Which is the most common cyanotic congenital heart disease in children? It is tetralogy of Fallot. But which is the most common cyanotic congenital heart disease in newborns? It is TGA, transposition of the great arteries. So most common congenital heart defect, VSD, ventricle septal defect. Most common cyanotic congenital heart defect, tetralogy of Fallot. And most common cyanotic congenital heart defect in newborns is transposition of the great arteries, TGA. Then certain syndromes and their association with heart diseases. So most common congenital heart disease in Down syndrome is endocardial cushion defects. Most common congenital heart disease in Turner syndrome is bicuspid aortic valve and coarctation of aorta. Most common congenital heart defect in Noonan syndrome is valvular pulmonary stenosis. Most common congenital heart defect in congenital rubella syndrome is patent ductus arteriosus. So in Down syndrome, the most common congenital heart defect is endocardial cushion defect. In Turner syndrome, most common congenital heart defect is a type of aortic stenosis, which is called as a bicuspid aortic valve. And a second heart defect, which is very commonly seen in Turner syndrome, is coarctation of aorta. Then most common heart defect seen in Noonan syndrome is a valvular pulmonary stenosis. And most common heart defect seen in congenital rubella syndrome is a patent ductus arteriosus. And another syndrome, which is important, I feel now you should remember about that also, is the most common congenital heart defect in a syndrome called as the Williams syndrome. It is supravalvular aortic stenosis. So Williams syndrome is a syndrome that is associated with, I think, mutation on chromosome 7. And Williams syndrome is associated with features like hypercalcemia, poor weight gain, then stellate shaped iris. Stellate is like spokes of a wheel. So stellate shaped iris. Important thing जो आपको याद रखनी है, important thing that you remember is Williams syndrome is associated with mutation on chromosome 7 and it can be associated with congenital heart defects. The most common congenital heart defect in Williams syndrome is supravalvular aortic stenosis. So repeat with me, most common congenital heart defect in Down syndrome, endocardial cushion defect. Most common congenital heart defect in Turner syndrome is bicuspid aortic valve, coarctation of aorta. Most common congenital heart defect in Noonan syndrome is valvular pulmonary stenosis. Most common congenital heart defect in congenital rubella syndrome is patent ductus arteriosus, and most common congenital heart defect in Williams syndrome is supravalvular aortic stenosis. For Marfan syndrome, yes, I think mitral valve prolapse is very common. But since This is not commonly asked in the exam, so we do not teach it. Now, some important X-rays and their association with congenital heart diseases. So, first is sign of three appearance, which is seen in coarctation of aorta. Then a boot-shaped heart, which is seen in children with tetralogy of Fillet. Then a box-shaped heart, which is seen in children with Epstein's anomaly. Then egg on string appearance, seen in children with transposition of great arteries, and snowman's heart or figure of eight appearance, seen in supracardiac total anomalous pulmonary venous return. Supracardiac total anomalous pulmonary venous return. So these are some signs which you should remember for your exams. X-ray signs. Sign of three seen in coarctation of aorta. Boot-shaped heart seen in tetralogy of Fillet. Box-shaped heart seen in Epstein's anomaly. Epstein's anomaly, by the way, you must be knowing, Epstein's anomaly is the heart defect commonly associated with lithium intake in pregnancy. So when mother takes a teratogen, which is lithium, during pregnancy because of any reason, I think it's an antipsychotic drug. So it is can be taken in pregnancy. It can be associated with heart defects in the baby, such as Epstein's anomaly. Then egg on string appearance seen in transposition of great arteries, and snowman's heart appearance is seen in supracardiac TAPVR. I think for your exams, just remember this much about heart diseases. Plus, obviously, you should also, one more thing that you should remember about heart diseases are the acyanotic and cyanotic heart diseases. So I won't go into the details of acyanotic and cyanotic heart diseases, but just very quickly, I will just very quickly tell you how congenital heart diseases are divided. So congenital heart diseases are divided into they are divided into acyanotic congenital heart diseases and cyanotic congenital heart diseases. So first, congenital heart diseases are acyanotic, which do not present with cyanosis, and the other congenital heart diseases are cyanotic, which present with cyanosis. Acyanotic heart diseases include heart diseases such as atrial septal defects, ventricle septal defects, patent ductus arteriosus, endocardial cushion defects, which I told you is commonly seen in Down syndrome. The more commonly used term for endocardial cushion defects now is atrioventricular septal defects. Atrioventricular septal defects. Then aortic stenosis, pulmonary stenosis, and coarctation of aorta. So these are important acyanotic congenital heart diseases. Why are they called as acyanotic congenital heart diseases? Because they are not associated with any cyanosis. Cyanotic congenital heart diseases, on the other hand, are heart diseases which are associated with either decrease in the pulmonary blood flow or increase in the pulmonary blood flow. So, heart diseases associated with reduced pulmonary blood flow and heart diseases which are associated with increase in the pulmonary blood flow. When we say blood flow is decreased, we also call it as pulmonary oligemia. Oligemia. Pulmonary oligemia means the pulmonary blood flow is reduced. And when the pulmonary blood flow is increased, we call it as pulmonary plethora. So when the pulmonary blood flow is reduced, we call it as pulmonary oligemia. And when the pulmonary blood flow is increased, we call it as pulmonary plethora. Now, cyanotic heart disease with reduced pulmonary blood flow, which means pulmonary oligemia, They are further divided up into two broad categories. First, cyanotic heart diseases associated with right ventricle hypertrophy and those associated with left ventricle hypertrophy. So if I ask you which cyanotic heart disease is associated with reduced pulmonary blood flow and is associated with the right ventricle hypertrophy, answer is tetralogy of Philip. And which cyanotic heart disease is associated with reduced pulmonary blood flow and left ventricle hypertrophy? It is tricuspid atresia. So cyanotic heart disease associated with reduced pulmonary blood flow further divided up into that with right ventricle hypertrophy and that with left ventricle hypertrophy. Cyanotic heart disease with reduced pulmonary blood flow with the right ventricle hypertrophy is tetralogy of Philip. And cyanotic heart disease with reduced pulmonary blood flow with the left ventricle hypertrophy is tricuspid atresia. And which heart diseases come under heart disease come under cyanotic heart disease with increased pulmonary blood flow? So I'll write it here. First is transposition of great arteries. Second is total anomalous pulmonary venous return. Third is truncus arteriosus. And fourth is a hypoplastic left heart syndrome. So we divide congenital heart disease to acyanotic, cyanotic. Acyanotic includes ASDs, VSDs, patent ductus arteriosus, endocardial cushion defects, aortic stenosis, pulmonary stenosis, and coarctation of aorta. Cyanotic heart diseases again divided into two types: cyanotic heart disease with reduced pulmonary flow, increased pulmonary flow. Cyanotic heart disease with reduced pulmonary blood flow or pulmonary oligemia further divided into those with right ventricle hypertrophy, those with left ventricle hypertrophy. So right ventricle hypertrophy example is tetralogy of Philip. Left ventricle hypertrophy example is tricuspid atresia. Tetralogy of Philip, as you know, has four main features. First is right ventricle hypertrophy. Second is pulmonary stenosis. Third is a large ventricle septal defect. And fourth is an aorta which overrides. So there are many times students asking, so what is meant by aorta overriding the ventricle septal defect? That means aorta starts from above the ventricle septal defect. And which cyanotic heart disease are associated with increase in the pulmonary blood flow, transposition of great arteries, total anomalous pulmonary venous return, truncus arteriosus, and a hypoplastic left heart syndrome. If you remember this much congenital heart diseases, I think it is more than enough. My experience is it's more than enough for your FMGE exams. Are you now confident in heart diseases? Whatever heart diseases I've told you, are you feeling confident with it? I think this much about heart disease is more than enough for your FMGE exams. Particularly talking about the X-rays, most common heart disease, most common cyanotic heart disease, most common cyanotic congenital heart disease in newborns. Then, very important topic which you should remember is the syndromes and their association with different heart diseases. Let us now come to neurology. Some important topics related to pediatric neurology. Now, in neurology, I will first talk about neural tube defects. So, in neural tube defects, which are congenital neurological disorders seen in children, the most important thing that is asked is the doses. The doses of folic acid that should be given to prevent neural tube defects. So, to prevent neural tube defects, what doses of folic acid should be given? So, for primary prevention, there is a different dose. And for secondary prevention, there is a different dose. So for primary prevention, there is a different dose. And for secondary prevention, there is a different dose. So if you are asked what is the dose of folic acid for primary prevention of neural tube defect, that means there has never been an incidence of neural tube defect in the past. What is the dose of folic acid? Answer should be 0.0 Answer should be 0.4 milligrams of folic acid per day. But for secondary prevention, the dose of folic acid should be 4 milligrams of folic acid per day. So please remember this for your exam. This again is very, very important topic for your exams. So the dose of folic acid, 0.4 milligrams of folic acid per day. For primary prevention of neural tube defects, 4 milligrams of folic acid per day for secondary prevention of neural tube defects. And ideally, this dose of folic acid should be started before conception, about 1 month before conception, and should be continued till about 3 months of pregnancy. Then another very important topic in neurology, which I feel is relevant for your examination point of view, is the seizures, fits in children. So they often ask the drug of choice for neonatal seizures and the drug of choice for childhood seizures. So what is the drug of choice for neonatal seizures? The drug of choice for neonatal seizures is phenobarbital. And what is the drug of choice for childhood seizures? The drug of choice for childhood seizures is midazolam or lorazepam. Please remember for your exams. So if someone asks you for childhood seizures, what is the drug of choice? For childhood seizures, the drug of choice is midazolam or lorazepam. Basically benzodiazepines. But for neonatal seizures, the drug of choice always is phenobarbital. Then another very important topic related again to seizures only is the absence seizures, infantile spasms, and juvenile myoclonic epilepsies. So these are 3 important types of seizures or epilepsies which are seen in children. Absence seizures, infantile spasms, and juvenile myoclonic epilepsies. The drug of choice for an absence seizure is ethosuximide. The drug of choice for an absence seizure is ethosuximide. But if ethosuximide is not available, then sodium valproate can be used. So drug of choice is ethosuximide for absence. What is an absence seizure? Sudden stoppage of the activity. So a child is doing something and he suddenly stops in between. So sudden stoppage of the activity, cessation of the activity. The child appears blank. And there is no post-ictal confusion. So as soon as the seizure ends, the child resumes his activity. So no post-ictal confusion. The drug of choice for absence seizures is ethosuximide, but there are availability issues of ethosuximide, so sodium valproate can be used in such cases. Infantile spasms, the drug of choice is always injections of ACTH. Infantile spasms. What are infantile spasms? Infantile spasms are basically tonic clonic spasms which occur in infants. So there can be a sudden increased tone or sudden jerks which can occur in infants, or head nods like this, which is why this is sometimes also known as the salam seizures. So they are sometimes also called as the salam seizures. It is also called as the West syndrome, and the drug of choice for infantile spasms is injections of ACTH. Vigabatrin can be used as a second line drug. Vigabatrin can be used as a second line drug. Vigabatrin is only the first line drug in infantile spasms associated with tuberous sclerosis. Tuberous sclerosis is actually a type of a neurological disorder, which sometimes in children can be associated with infantile spasms. So when infantile spasms occur in tuberous sclerosis, then the drug of choice is not ACTH. Then the drug of choice is vigabatrin. But otherwise, if you are just asked infantile spasms, what is the treatment of choice? Answer is ACTH. And juvenile myoclonic epilepsies are seizures that occur in adolescents, like the name juveniles. So they occur in adolescents, and the drug of choice again is sodium valproate. Most juvenile myoclonic epilepsies occur in the early morning hours. So most fits in juvenile myoclonic epilepsies occur in the morning hours. So there is a sudden jerk in the hand and the things can drop from the child's hand. So drug of choice for absence seizures, ethosuximide. Ethosuximide not available, sodium valproate. Drug of choice for infantile spasms, ACTH. But when infantile spasms is associated with tuberous sclerosis, then the drug of choice is vigabatrin. And drug of choice for a juvenile myoclonic epilepsy is sodium valproate. Then another important topic for your exams is cerebral palsies, neurological disorder which is called cerebral palsies. Now, cerebral palsies are non-progressive neuromotor disorders. Non-progressive neuromotor disorders that occur due to injury to the brain very early in life. So brain in a fetus or in a newborn is growing very, very rapidly. At that very crucial time, any injury, if it occurs to the brain of a growing fetus or newborn, it can result in a non-progressive neuromotor disorder, which is called as a cerebral palsy. Cerebral palsies usually can occur because of injuries to the brain. And that injury to the brain can be because of prematurity. That injury to the brain can be because of a child being born low birth weight. That injury to the brain can be because of kernicterus. That injury to the brain can be because of meningitis in the neonatal period. That injury to the brain can be because of torch infections. So anything that injures your brain in the very, very early period of life, that can result in a disorder which is called a cerebral palsy. The most common risk factor for cerebral palsy is prematurity. Now, what are the types of cerebral palsies? Well, the types of cerebral palsies are: one, spastic cerebral palsy. The second type of cerebral palsy, dyskinetic cerebral palsy. Third type of cerebral palsy is ataxic cerebral palsy. And fourth type of cerebral palsy is mixed cerebral palsy. And which is overall the most common type of cerebral palsy seen in children? Most common type of cerebral palsy in children is spastic cerebral palsy. So if someone asks you which is the most common type of cerebral palsy that you see in children, it is a spastic cerebral palsy. So I think in neurology, neural tube defects, very important, especially the doses of folic acid in neural tube defects, very important. Then seizures, the drug of choice for childhood seizures, drug of choice, neonatal seizures, very important. Then another very important topic, absence seizures, infantile spasms, juvenile myoclonic epilepsies, their drugs of choice. Then cerebral palsies. So at least this much about neurology you should be familiar with. And I think again these are topics which I feel are very important topics from neurology for your FMG point of view. So when we are revising, this again is a very, very important group of topics which will come from neurology. Now, coming to nephrology. Now, nephrology is about kidney disorders. Now, what questions can come from kidney disorders? Well, the most common congenital cystic disorder, most common congenital cystic disorder of the kidney in children is multicystic dysplastic kidney. So students wrongly believe that polycystic kidney disease, students wrongly believe that polycystic kidney disease is the most common congenital cystic disorder of the kidney. No. Polycystic kidney disease is not the most common congenital cystic disorder of the kidney. The most common congenital cystic disorder of the kidney in children is multicystic dysplastic kidney. This is in children. Then if somebody asks you which is the most common tumor of the kidney in children, the most common malignancy. When I say tumor, that means malignancy. Most common malignancy of the kidneys in children. It is Wilms tumor. It is Wilms tumor. This is the most common tumor of the kidney that is seen in children. But if they ask you which is the most common tumor of the kidney, but now they changed and ask not in children but in newborns. So now initially they were asking most common tumor of the kidney in children. So when they say most common tumor of the kidney in children, answer is Wilms tumor. But Wilms tumor is very, very rare below 5 to 6 months of age. So in small children, especially newborns, Wilms tumor is usually very, very rare. So if I now ask the question, which is the most common tumor of the kidney in newborns, then the answer is a then the answer is a mesoblastic nephroma. So Wilms tumor is the most common tumor of the kidney in children, but the most common tumor of the kidney in newborns is a mesoblastic nephroma. Then there is another topic which is often asked in the exams, and that topic in children is vesicoureteric reflux. In short, we also call it as a VUR, vesicoureteric reflux. VUR. What is a vesicoureteric reflux? It's a retrograde reflux of urine. Normally, urine always flows in one direction from the kidney down into the lower part of the urinary tract. So from the kidney, the urine flows down into the urinary tract, one direction. But when the urine starts refluxing in the opposite direction, then that condition is called as VUR. And what you will expect when the urine will start refluxing in an opposite direction, it will send infections from the lower part of the urinary tract into the kidneys. So VUR is a congenital disorder in children which is associated with recurrent urinary tract infections. So one of the most common causes of recurrent UTIs in children is a vesicoureteric reflux. This is a congenital disorder of the urinary tract. Like neural tube defect was a congenital disorder of the nervous system, vesicoureteric reflux is a congenital disorder of the urinary tract. And the best way to diagnose best test to diagnose a vesico-ureteric reflux is the micturating cystourethrogram. So if you are asked which is the best test to diagnose the vesico-ureteric reflux in children, it is micturating cystourethrogram. So if a child presents with a UTI, a young child, you should suspect a vesico-ureteric reflux, and the best test to diagnose a vesico-ureteric reflux is a micturating cystourethrogram. Then another topic which is important from your examination point of view is nephrotic syndrome in children. Nephrotic syndrome in children. This again is a very important topic from your pediatrics point of view. So, what are the definitions of pathological proteinuria? What are the definition of pathological proteinuria? So, when we say nephrotic syndrome means there is a large amount of protein being lost in the urine. We say pathological proteinuria, large amounts of proteins being lost in the urine. So, when the urine protein excretion is more than 1000 milligrams per meter square per day, or when the urine protein excretion is more than 40 milligrams per meter square per hour, or the urine protein is to creatinine ratio is more than 2. These are the definitions of pathological proteinuria. This is very, very important. The definitions of pathological proteinuria in children. Urine protein excretion more than 1000 milligrams per meter square per day, or urine protein excretion more than 40 milligrams per meter square per hour, or urine protein is to creatinine ratio more than 2. This is the definition of nephrotic syndrome in children. And the most common type of nephrotic syndrome, most common type of nephrotic syndrome, rather I should say most common cause of nephrotic syndrome is minimal change disease. Unlike the most common cause of nephrotic syndrome in adults, which is focal segmental glomululosclerosis, in children the most common cause of nephrotic syndrome is minimal change disease. And minimal change disease shows excellent response to steroids. Therefore, the drug of choice is corticosteroids. So what is the drug of choice for nephrotic syndrome in children? It is corticosteroids. A 12 weeks course of corticosteroids is given for the treatment of nephrotic syndrome in children. First 6 weeks you give 2 milligrams per kg daily of prednisolone, 2 milligrams per kg daily of prednisolone for the first 6 weeks. And then you shift the child to low dose alternate day steroids, which is 1.5 milligrams per kg of prednisolone every alternate day. First, you were giving prednisolone 2 milligrams per kg every day for 6 weeks. Then you reduce down the dose and give 1.5 milligrams per kg every alternate day and give for another 6 weeks. So this is the nephrotic syndrome treatment in children. So if someone asks you what is the drug of choice for nephrotic syndrome treatment in children, it is corticosteroids. However, there are two types of nephrotic syndromes in which alternative drugs are used. One is a steroid dependent nephrotic syndrome. Steroid dependent nephrotic syndrome. The other is a steroid resistant nephrotic syndrome. So one is a steroid dependent nephrotic syndrome and the other is a steroid resistant nephrotic syndrome. So what is the drug of choice for a steroid dependent nephrotic syndrome? So for steroid dependent nephrotic syndrome, the drug of choice usually is levamisole. Mycophenolate and cyclophosphamides can also be used, but the drug of choice usually, unless and until there is a very significant steroid toxicity in a steroid dependent nephrotic syndrome. If there is no significant steroid toxicity, the drug of choice for treating steroid dependent nephrotic syndrome, just remember, is levamisole. While the drug of choice for treating steroid resistant nephrotic syndrome is cyclosporin or tacrolimus. So cyclosporin and tacrolimus are the drugs of choice for steroid resistant nephrotic syndrome, while for steroid dependent nephrotic syndrome, the drug of choice is levamisole. I hope you are understanding everything. Please try to understand. This is very challenging when you have to teach everything in just about 2 hours time. You are trying to revise the whole of pediatrics in 2 hours time. So you choose which are the important topics and you try to summarize each of those topics in the best possible way. In classes, when we are taking the classes, there are multiple revisions. And I make it a point that I multiple times revise the topic so that students get the things in their head. This is a revision class. So in the revision class, the basic idea is to make you understand what are the important topics and just try to summarize those topics in such a way that you are able to retain those topics for your exams. This revision should be very helpful just before your final exams come. So we are trying to revise the whole of pediatrics in the best possible way. Now let us come to respiratory disorders in children. Respiratory disorders in children. Now, in respiratory disorders, most of the disorders that are there are many of the disorders are basically overlapping with ENT. So, if I ask you which is the most common cause of croup in children, the most common cause of croup in children is parainfluenza viruses. Which is the most common cause of epiglottitis in children? The most common cause of epiglottitis in children is H influenza viruses, H influenza bacteria, and even Streptococcus pneumonia. I think your ENT faculty will be able to tell better, but I personally feel that if they ask one single bacteria which is most common cause of epiglottitis in children, epiglottitis is now becoming a very rare problem in children. It is now more commonly seen problem in adolescents and adults. But in children still, I think H influenza should be considered. H influenza should be considered as the most common cause of epiglottitis, and parainfluenza viruses should be considered as the most common cause of croup in children. Then the most common cause of bronchiolitis in children. Most common cause of bronchiolitis in children. Most common cause of bronchiolitis in children is respiratory syncytial viruses, RSV. Respiratory syncytial virus is the most common cause of bronchiolitis in children. Then another disorder that you should remember for your exams is cystic fibrosis. Cystic fibrosis. Cystic fibrosis is an autosomal recessive disorder which is associated with mutation in CFTR gene. So it is associated with mutation in CFTR gene. The full form of CFTR is cystic fibrosis transmembrane regulatory gene. So this codes for a protein which is called as CFTR, cystic fibrosis transmembrane regulatory protein. And this CFTR protein controls the movement of sodium and chloride across different hollow ducts of the body. So it controls the movement of sodium and chloride in the hollow ducts of the body, like the pancreatic duct, like the bile duct, like the respiratory tract, like the intestine. So wherever there is a hollow duct in our body, the movement of sodium and chloride through those ducts is controlled by the CFTR protein. And the gene that controls for the CFTR protein gets mutated in cystic fibrosis. So the protein becomes defective. More than 1,500 mutations are known to occur, and the most common mutation is delta F508 mutation. If someone asks you which is the most common mutation of cystic fibrosis, it is delta F508. Delta means deletion. F means phenylalanine. So deletion of phenylalanine from position 508. Deletion of phenylalanine from position 508 on chromosome 7 is the most common mutation seen in cystic fibrosis. Deletion of phenylalanine from position 508 on chromosome 7 is the most common mutation of cystic fibrosis. And what happens in cystic fibrosis is the secretions become dry in the hollow ducts of the body. So respiratory mucosa becomes dry. The cilia in the respiratory tract do not function properly. So infections can enter into the respiratory tract. So recurring chest infections, thick secretions blocking the airways. So productive cough. Pancreatic secretions do not reach the intestine. So pancreatic insufficiency. Protein malabsorption. Bile does not flow. So fat malabsorption. What is the best test? It is sweat chloride test. So what you do here is measure the levels of chloride in the sweat sample. That is the best test for cystic fibrosis. Other than that, another test that can be done is check for mutations. Check for mutations in the CFTR protein. So minimum 2 mutations in the CFTR gene. 2 mutations which are specific to cystic fibrosis. If we can identify them, we say this is cystic fibrosis. So minimum 2 mutations, if they can be identified, we say this is cystic fibrosis. But I still feel if they ask you what is the best test for cystic fibrosis, it should be the sweat chloride test. And more is the level of chloride in the sweat sample, more easily we'd say this is cystic fibrosis. Which is the only gland that does not get blocked, which is the only duct that does not get blocked in cystic fibrosis because of those dry secretions. It is the sweat duct. So sweat duct does not get blocked. All other ducts, hollow ducts of the body get blocked. But the only duct that does not get blocked in cystic fibrosis is the sweat duct. Then gastroenterology. And in gastroenterology, most of the topics that we teach in gastroenterology overlap with the topics of pediatric surgery. For example, Hirschsprung disease. So I won't go into the details about Hirschsprung disease, hypertrophic pyloric stenosis, because they are taught in surgery. I will rather tell you about management of dehydration. It's a very important topic, dehydration management in children. So there is a question, what are the levels of chloride in the sweat, which tells us about cystic fibrosis. So chloride levels more than 60 milliequivalents per liter means a positive test. And chloride levels less than 30 milliequivalents per liter means a negative test. So levels more than 60 milliequivalents per liter means a positive sweat chloride test, and levels less than 30 means a negative test. Coming to dehydration management in children. So there are three types of dehydration in children. One is no dehydration. One is some dehydration. And one is severe dehydration. So no dehydration in children, some dehydration in children, and severe dehydration in children. Now, no dehydration means the child appears to be alert. The child does not have any evidence of dehydration. He is alert. No dryness of the mucosa. No skin pinch delay. So the treatment of no dehydration is ORS. So whenever the child wants, as much as thirsty the child is, he can take ORS. But there is not much signs of dehydration that is seen in no dehydration. In the past, we used to call this type of dehydration as mild dehydration. Now, some dehydration is a type of dehydration which in the past was called as moderate dehydration. Now we call it as some dehydration. So here the child in some dehydration becomes irritable. The child is thirsty. So in the exams, if they ask a child is thirsty, he appears to be restless, irritable. You pinch a fold of skin, it is delayed. This is some dehydration. And the treatment of some dehydration is ORS 75 ml per kg given over a period of 4 hours, plus maintain the child then in hydration. So the main treatment of some dehydration is ORS given at a rate of 75 ml per kg of ORS over 4 hours. And once the dehydration has been corrected, then maintain hydration in the child. The treatment of this group of children is ORS. Now, severe dehydration is the one which is dangerous, and the treatment of this is IV fluids, especially ringer lactate. If ringer lactate is not there, normal saline. Less than 1 year, severe dehydration is managed by giving 30 ml per kg of IV fluid over 1 hour, and then 70 ml per kg of IV fluid over 5 hours. So how do you manage? 30 ml per kg of IV fluid is given over 1 hour and 70 ml per kg. ORT is oral rehydration therapy that you prepare at home. So that is the same as ORS. So in no dehydration, there is a student asking, should it be ORT? ORT is the oral rehydration that you are preparing at home. So you can say ORT or you can say ORS. That remains the same. So less than 1 year, 30 ml per kg of IV fluid is given over 1 hour, followed by 70 ml per kg over 5 hours. And more than 1 year, 30 ml per kg of IV fluid is given over half an hour, and 70 ml per kg of IV fluid is given over 2.5 hours. So less than 1 year, 30 ml per kg of IV fluid is given over 1 hour and 70 ml per kg over 5 hours. But when the child is more than 1 year, 30 ml per kg of IV fluid is given over half an hour and 70 ml per kg is given over 2.5 hours. So this is the treatment of severe dehydration in children. So no dehydration and some dehydration are managed by oral solutions. But severe dehydration is managed by IV fluids. Regarding miscellaneous topics, one of the miscellaneous topics which I would just like to talk about is infections. And in infections, just remember a few important things about measles and chickenpox. So first thing that they ask in measles is the most common complication of measles and the least common complication of measles. Most common complication of measles is otitis media, and least common complication of measles is SSPE, subacute sclerosing panencephalitis. So if someone asks you which is the most common complication of measles in children, it is otitis media. And which is the least common complication of measles in children? It is subacute sclerosing panencephalitis. What is the full form of SSP? Subacute sclerosing panencephalitis. Then which is the most common complication of chickenpox in children? Most common complication of chickenpox in children, it is superadded bacterial infections. Superadded bacterial infections. So most common complication of chickenpox is superadded bacterial infections of the skin. Then mumps. Most common complication of mumps, in pre-adolescent children. And most common complication of mumps in adolescent children. So which is the most common complication of mumps in pre-adolescent children? That means children who are in the pre-adolescent age group, less than 10 years of age. Most common complication of mumps in this age group is meningoencephalitis. And most common complication of mumps in the adolescent age group is orchitis. So most common complication of mumps in the pre-adolescent age group is meningoencephalitis. Most common complication of mumps in the adolescent age group is orchitis. Then there are some lesions seen on the mucosa in some infections. So let us see what are those lesions. First lesions that is seen, or we can say some spots seen on the mucosa in children. So one is Koplik spots. So Koplik spots are seen in measles infection. Then Forshima spots. Forshima spots are seen in rubella infections. Then Nagayama spots. Nagayama spots are seen in Roseola infantum. Roseola infantum is also called as the sixth disease. Roseola infantum is also called as the sixth disease. It is caused by human herpes virus 6. So question is, where is Koplik spot seen? Koplik spots are seen opposite the molar tooth, buccal mucosa. So where are Koplik spots seen? Koplik spots are seen in the inside buccal mucosa, opposite the molar teeth. So opposite the molar teeth. Where are Forshima spots seen? Forshima spots seen in the palate. Where are Forshima spots seen? Forshima spots seen in the palate, in rubella. Where are Nagayama spots seen? Nagayama spots are again seen on the uvula and the palate. Uvula and palate. Nagayama spots are seen in uvula and the palate in sixth disease. Sixth disease is also called as Roseola infantum. It is caused by human herpes virus 6. So these are some of the lesions or some of the spots. Mumps has not been eradicated, smallpox has been eradicated. So there is a student who's asking, has mumps been eradicated? Mumps has not been eradicated. Mumps is basically a parotitis, parotid infection or inflammation. So this much is again important from your infections point of view. So I think with this much, I think uh, I feel these are the important things which I felt are the must-do topics from pediatrics. And if you do this much before your exams, I think it will help you, should help you in revising pediatrics quickly. Plus, obviously, you need to read your notes properly. But even if you do this much, I think it should help you in probably securing quite a decent rank. And if you prepare your notes and if you've read your notes properly, then I think it will be very helpful for your exams. I hope you have all liked this class, this revision class. For those students whom I might meet later on for your regular batch classes of FMG, I will probably discuss pediatrics in much more detail, and probably I can at that time revise with you as many times as I would also like, so that things go into your head and you are able to retain those things before your exams. So overall, thank you very much for being a participant in this revision class. I wish you all the best for your January FMG exams, and I hope to see you all successful in those exams. Best of luck from my side for your January FMG exams, and thank you very much, and goodbye. So there is a question, what about parotitis is not common in mumps? As I said, mumps is basically a parotitis. So parotitis is commonly seen in mumps. How many questions do you think, sir, will be asked from these topics? I think should be around 4 to 5 questions, 6 questions, I think. If you read your notes properly, probably you can answer almost all the 10 to 12 questions that will be asked in the exams. Right? So thank you very much and goodbye.